Amy Hendrickson is a registered dietitian nutritionist and medical affairs manager, specializing in pediatrics with Nestle Health Science. She earned her Bachelor's of Science in Human Nutrition and Dietetics from the University of Illinois in Chicago in 2001, and her Master's in Public Health from Northwestern University in 2008. Prior to joining the medical affairs team at Nestle in 2009, Amy worked as a pediatric registered dietitian and nutrition department manager at La Rabida Children's Hospital in Chicago for 8 years. At La Rabida, Amy provided nutrition assessment management and education of children, adolescents, and their families with medical conditions such as diabetes, obesity, failure to thrive, cerebral palsy, intestinal failure, burns, bronchopulmonary dysplasia, and other conditions associated with prematurity. Amy has presented lectures to healthcare providers on various topics for over 15 years, including enteral nutrition in pediatric critical care, nutrition for the neurologically impaired child, nutrition management of diabetes in children and childhood obesity. Amy, the floor is yours.
Thank you, Elaine, for that wonderful introduction. Today I will be presenting on nutrition and children with developmental disabilities, assessment, impact, and evidence-based management. So the objectives of the talk today, we want to look specifically at cerebral palsy. So developmental disabilities obviously encompass other conditions aside from cerebral palsy, but the most evidence is in that condition. So we really want to describe that condition and describe the prevalence. We want to talk about the importance of nutritional care for children with cerebral palsy and also developmental disabilities of other sorts and the impact of nutrition on this particular population. Talk about tools that can be used to assess the nutritional status of these children. There are some very specific issues that may interfere with adequate nutrition and how to address those. And then review the evidence around improving feeding tolerance in this population. So just to really kind of give a very brief introduction to cerebral palsy. So this is a neurological disorder caused by a non-progressive brain injury that typically is going to occur while the children's brain is under development. Of course, this can happen later in life due to a lack of oxygen to the brain that causes a brain injury.
Okay, I heard that I lost audio, so I'm hoping that you can hear me now. Hopefully we won't have issues going forward. So I think I left off talking about motor patterns of cerebral palsy. So quadriplegia, of course, is the most severe of the motor patterns, and that affects all 4 limbs. Diplegia is really just mostly affecting the legs. The arms can be mildly affected. Hemiplegia is one side of the body. Triplegia is both arms and one leg. And then monoplegia is only one limb. Usually an arm is affected. And there's a specific classification for cerebral palsy called the Gross Motor Function Classification System. And this really helps us determine severity of the disease. And part of this is actually determining what potential feeding difficulties might be present and how to really address those based on this classification system. So Gross Motor Function Classification System Level 1, really children don't really even look as if they're affected. You might not be able to tell. They might just have some issues with speed or balance or coordination. Level 2, children really just need to hold a railing when they're walking upstairs, and they might have some additional limitations walking on uneven surfaces. Level 3, children may need an assistive mobility device, but they potentially can walk short distances on their own. Level 4, they still may continue to walk for short distances, but really might rely on a walker or other assistive device. And then level 5 is really the most severe, where typically these children are not able to walk, typically aren't able to feed on their own, and even need neck and trunk support assistance. So the importance of nutrition in developmentally delayed children cannot be overstated. Malnutrition can affect a very large proportion of these children. Also, overnutrition, there's a small percentage that really can suffer from overnutrition. And of course, these are typically children that are enterally fed. Undernutrition in the literature, up to 46% of children if you're looking at the range that's found in the literature. And linear shunting also can affect almost a quarter of these children. And malnutrition really used to be considered part of the disease 25, 30 more years ago. It was kind of believed to be unavoidable. It just kind of went hand in hand with cerebral palsy. And we now understand that poor growth affects outcomes. And there's a whole host of poor outcomes that are associated with malnutrition in this group. Malnutrition has been associated with this laundry list of poor outcomes: increased risk of infections and hospital length of stay, increased healthcare costs, increased complication rates and readmission rates, increased mortality risk, poor growth, reduced mental and psychomotor development, and also increased behavioral problems. So a lot of poor outcomes associated with malnutrition. And if you're specifically looking at the importance of nutrition in developmentally delayed children, there is a body of evidence showing that by improving nutritional status in these children, you can improve gross motor skills, decrease irritability and spasticity, improve peripheral circulation, and help heal and also prevent pressure ulcers. Also, this may help improve gastroesophageal reflux and just improve quality of life and overall health. So improving nutritional status is really critical in this population. There are, of course, some non-nutritional factors that affect growth in this particular population. So those are related to the disease. The severity of malnutrition correlates with the severity of the disease. This disease, as you saw from the gross motor function classification system, it can be very mild. A level 1 child probably is just going to eat just fine and have a normal body weight. A level 5, especially if that child is not tube fed, it doesn't have any type of nutrition support, the risk of malnutrition goes way up for a level 5 child. The neurological disease affects growth even in the absence of nutrition. And really, body composition of these children is different. Their statural growth is affected whether they're adequately nourished or not. They tend to have less lean body mass, more fat mass, and they said, as I said, statural growth is going to be affected. And demonstrating this, patients that have spastic hemiplegia, so only one side of the body affected, they have significantly smaller measures of breadth and length on the affected side. Of course, there are nutritional factors that affect growth too, the largest one being inadequate intake. Caloric intake in this group of patients has been shown to be lower than age-matched controls, and those able to feed themselves may lack coordination and speed. So really the help of a caregiver to be kind of in touch with that child in terms of their cues and whether or not they're struggling or whether or not they've had enough to eat or they're, they have satiety or non-satiety. A caregiver really needs to be very much in tune with the child to be able to accomplish that. But even accomplished caregivers may not be able to communicate with that child in terms of hunger and satiety. So that can be a challenge as well. So I wanted to show this. This is the Oxford feeding study that was published in 2012. And this looked at almost 300 children with cerebral palsy and found some common feeding problems, included a need for help with feeding. That was almost all of the children in this study, choking with eating, feeding time of greater than 3 hours per day, constipation, frequent vomiting, feeding described as stressful and unenjoyable. And almost 65% of these patients never had a feeding or nutritional assessment. So a lot of common issues with children that have cerebral palsy. I'm not going to read this entire thing. I thought this would be very, very helpful, this algorithm showing all of the different factors that contribute to inadequate nutritional intake. So all of those boxes kind of on top with the arrows pointing down to the inadequate nutritional intake, environmental factors, behavior and emotional factors, pain with eating, which can include gastroesophageal reflux, constipation, inappropriate feeding, neurological impairment such as head control and abnormal muscle tone can really affect that. Oral motor dysfunction, which we'll talk in a little bit more detail in a few slides. Their growth and fine motor ability, their cognitive ability, and GI problems like delayed gastric emptying or constipation. All of these factors can contribute to inadequate nutritional intake. And then you see the arrows pointing outward. These are all the things that inadequate nutritional intake can lead to parental stress and family stress, poor general health, poor growth, suboptimal fat deposition. So it's really a large problem there's a lot of different factors involved. And also these children have a different metabolism. Resting energy expenditure tends to be lower than in age and weight matched controls. And total energy expenditure can be affected by a variety of different factors, including the type of neurological involvement. For example, a child with affectoid cerebral palsy actually needs more energy than a healthy control because they have this constant kind of churning of the muscle tone and actually causes them to burn more calories. Spasticity or hypotonia, depending on the type of muscle tone disorder that the child has, that can affect energy expenditure, and also their activity level, which is going to certainly be affected by whether or not they're ambulatory or not. And now I kind of want to talk a little bit about one of the bigger issues that affects intake and nutritional status, which is oral motor dysfunction. So as an infant, inadequate suction can really affect what the child is able to take via the breast or bottle, dysfunctional swallowing, persistent extrusion reflex. So extrusion reflex, of course, is that reflex in infants where the baby pushes food placed on their tongue out the front of their mouth with their tongue. And it usually disappears around 4 months of age when a child is safe to start oral feeding. And in a neurologically impaired child, this reflex persists, which causes challenges when you're trying to orally feed them because they're constantly thrusting the tongue out of their mouth and then pushing food out. So that can be a really big issue. Inadequate lip closure. Lip closure actually, of course, keeps food inside the mouth, and these children can have issues with that. So food can fall out of their mouths when they're trying to eat, and then reduced ability to chew. So, of course, the process of chewing and swallowing is a very complex series of actions that requires a high level of muscle coordination, and it's often not present in someone with neurological impairment. Some other illness-related factors include, as we already discussed, altered energy expenditure, inflammation, which can affect absorption, and decreased nutrient intake or altered nutrient utilization. Oral motor dysfunction can affect up to 90% of patients with cerebral palsy in some form or another. And per parental reports, up to 80% of patients with this disorder have been fed non-orally at least once as infants. Maybe that's a temporary NG or, whether or not they have to have a G-tube placed. So this is a major contributor to malnutrition. And the second bullet point I really want to stress, prolonged mealtime does not compensate for feeding inefficiency. So a prolonged mealtime, a mealtime that lasts an hour or longer, that child may not be getting any additional nutrients. They still may become malnourished. It's just going to become an exhausting and frustrating feeding experience for the child and also the caregiver. So this next section, I want to show some of the ways that you can evaluate nutritional needs of these patients. There's a lot of different tools, growth standards and nutrition assessment tools that I'd like to talk to you about. But first, of course, when you're looking at any chronic disease, you have to look at a multidisciplinary assessment that's going to include a variety of different specialists, including, of course, I put the dietitian right there up on the top, but, aside from the primary care physician, the child would need to potentially see a neurologist, different therapies, respiratory, radiology, and of course, GI. There are also a variety of ways to assess the nutritional status in this population of children. Some of these methods can be divided into anthropometrics and body composition, which really I'll be discussing today. Also methods for assessing bone status, as these children, especially non-ambulatory children, are at higher risk for osteopenia and osteoporosis. And there are some laboratory methods as well. I'm not going to be getting into that specifically today. I'm going to be talking more about looking at anthropometrics and body composition. So this is the first attempt at putting together growth charts specifically for children with cerebral palsy. And these really aren't used any longer This was done by Jackie Crick and colleagues at the Kennedy Krieger Institute, and these were published in 1996. It was a relatively small sample size, and really it was determined at a later time that probably many of these children that were in the sample were already malnourished. So these really aren't considered accurate growth charts, but this was kind of the first look at determining how these children grow. And now there are some growth charts that were developed and published in 2011. These are used much more commonly, a much, much larger sample size. This was over 102,000 measurements from over 25,000 patients. And these growth charts are stratified by gross motor function classification system. So, we went over at the beginning of this presentation, we went over the different levels. And I'll show you what these growth charts look like. What's interesting is that this red shaded area indicates an evidence-based link between low weight and mortality risk in children with cerebral palsy. So now you have these growth charts specifically for children with CP based on their GM-SCF level. And also you can see where these kids are going to be at higher risk of mortality in terms of their weight for age and also their weight for height and stature for age. So for levels 3 through 5, children with weight for age below the 20th percentile had significantly higher mortality rates compared with children with weight for age in the 20th to 80th percentile range. So this is really helpful just in terms of where you need to be when you're assessing these children and what kind of the danger zone is. So that's really helpful for children that use these, or for clinicians that use these growth charts. Now, I did want to talk about the ESPGHAN guidelines. So ESPGHAN actually published some guidelines for management of the gastroenterological and nutritional problems in neurologically impaired children. So I wanted to go over, these were published in 2017, so about a year and a half ago, and I wanted to go over some of the nutrition-related guidelines that were published. So actually, the ESPGHAN work group does not recommend the use of CP-specific growth charts. They recommend the use of the WHO growth charts. Specifically, this group stated that the CP-specific growth charts describe growth, which is not necessarily ideal, as they include many children with other health conditions that affect growth. So whereas I know in the U.S., there are many, many clinicians who use the Brooks growth charts, I did want to present the point of view of the ESPGHAN work group, who recommends the standard WHO growth charts. And the ESPGHAN work group also suggests the use of one of these, as they phrase it, red flag warning signs for the identification of malnutrition. So physical signs like decubitus skin problems and poor circulation, weight for age Z-scores of less than -2, tricep skin fullness of less than the 10th percentile for age and sex, mid-upper arm fat or muscle area of less than the 10th percentile, and then, of course, faltering weight and or failure to thrive. And Z-scores, I'm sure as dietitians, you're all using Z-scores. Z-scores kind of roared back into popularity after the meta paper that was published in 2013, titled Defining Pediatric Malnutrition, a paradigm shift toward etiology-related definitions. And it really showed that Z-scores are very much an evidence-based assessment tool that can identify malnutrition much more readily than standard growth charts. So they are now kind of the preferred method for assessment of growth parameters. They show us how a single data point compares to the norm, and they're more sensitive to small changes than percentiles. Because, for example, once you're kind of falling off the growth chart, you're underneath the 5th percentile in a standard growth chart. You can't really tell whether the child is improving or doing worse. And the Z-scores are much more sensitive to these small changes, whether or not the child is improving, if they have malnutrition. And of course, here is a weight for age Z-score chart for girls that I pulled up from the WHO. The median is 0, and then as you reach -2 and -3 underneath that median, then you're looking at malnutrition and severe malnutrition. I won't go over all of this, but this is a nice chart showing the application of Z-scores and how they relate to mild malnutrition, moderate malnutrition, and severe malnutrition. And then I've also included this WHO link, which is entitled, it's a module entitled Interpreting Growth Indicators, and it really just explains Z-scores in depth. I think it's a really nice document. And then pdtools.org, they have their Z-score application where you just punch in, the child's sex and their birth date and weight and height, and it'll give you the Z-score on this tool. So looking at weight and height, what does the ESPGHAN work group say? They recommend the assessment of nutritional status should not be based solely on weight and height measures. They recommend that knee height or tibial length should be performed routinely to assess linear growth. Many times these children their linear growth cannot be taken in the standard way because they have contractures and they can't really be straightened out. So that's one way, knee height or tibial length, that can be used to assess stature. So these alternative measures, they do have a high inter-rater reliability. They can be highly repeatable, and therefore they may be used on their own to monitor growth. Skin fold thickness is another recommendation. The work group recommends that the measure of fat mass by skin fold thickness should be used as a routine component of assessment because it can show changes in body fat. Another evidence-based assessment tool is mid-upper arm circumference. This correlates with BMI, but it's more sensitive to changes in muscle or fat mass. And you can see here that you have a fairly simple tool here that can be used to measure mid-upper arm circumference. And if you're using this tool, you show how it can be wrapped around the upper arm. If you're in the green area, that's normal. The small yellow area is higher risk of malnutrition, and then when you get into the red area, that is helps define and diagnose malnutrition. Energy requirements for this population, they are lower than healthy individuals, and there's a variety of different studies that indicate that the energy requirements are reduced. So some smaller studies by Bandini and Stallings, and also ASQ, showing that resting metabolic rate, fat-free mass, and total energy expenditure in children with CP are lower than healthy adolescents. Stallings did a study measuring energy expenditure, looking at children with spastic quadriplegia, and found resting energy expenditure was lower than the controls, and also total daily energy expenditure was lower than in the controls. And then another couple of smaller studies done here as well. Bandini et al. Measured resting metabolic rate in children with central nervous system impairment who were G-tube fed, and found that resting metabolic rate was overestimated. They used Harris-Benedict's equation, which of course should not be used in pediatrics, but also used the WHO equation, which is recommended, and found that those equations vastly overestimated measured resting metabolic rate. And then ASQ et al. Found that energy intake for children with CP was really just slightly above the resting metabolic rate. So really all the evidence points to the fact that energy expenditure is reduced and energy requirements, therefore, are also reduced in these children compared to age-matched controls. So what does the ESPGHAN work group say in their guidelines about estimating energy? They recommend the use of dietary reference standards for typically developing children. And then, of course, they recommend regular monitoring of body weight and fat mass. Of course, everyone kind of would agree that regular monitoring is required for any child with a chronic disease. Specifically, the ESPGHAN work group recommends the Schofield equation as the most accurate for estimating caloric needs in this population. In terms of protein needs, these children, I've kind of just presented a chunk of slides really showing that energy needs are lower, but these children actually have protein needs that are very similar to healthy individuals. First of all, looking at lean body mass, ambulant children and adults have reduced muscle volumes in their lower limbs. Some studies show that as low as 50% in their weight-matched typically developing peers. And the most significant muscle impairment is likely lack of muscle growth. And this really stems from the disease itself, but certainly nutrition impacts muscle growth as well as ambulation and the disease itself. So really supporting lean body mass is very important in this particular population of children. And looking at total body protein, children with developmental disabilities, they have declines in lean body mass. And again, this is related to inactivity. It's related, of course, to ambulatory status and the disease itself. But, of course, it's compounded by malnutrition. And, lack of adequate protein is part of that, and poor growth. So previously published studies show a reduction in body protein in children with spastic quadriplegia. So that, of course, you might guess this is, quadriplegia is the most severe form of cerebral palsy. And total body protein is important to measure because immune function, response, and recovery to disease, skeletal, respiratory, muscle function, all of these are impaired when body protein levels are low. So essentially, again, one more reason to really support lean body mass in this population. So what are the protein needs of these children? As I mentioned, adequate protein is still required to support growth and development, despite the fact that they have lower energy needs. So in absence of specific guidelines regarding protein needs for neurologically impaired children, the DRI is recommended. So the protein needs of a healthy individual is going to be the same as for a child with cerebral palsy. So they still need adequate protein. And what does the ESPGHAN work group say in their guidelines paper? They recommend the use of dietary reference intakes, as I just mentioned, for neurologically impaired children. And they also recommend the use of supplementary protein in specific situations. For example, if the child has decubitus ulcers or in children that have a very low caloric requirement. So supplementary protein could be in the form of a formula, an enteral formula that has a higher protein intake or has a higher protein content rather, or it can also be modulars as well. Many of these children are going to need nutrition support. Of course, enteral nutrition is really something that can help these children if oral intake is unsafe, if they have insufficient oral intake, or if their meals are excessive in duration. And the ESPGHAN work group recommends considering enteral feeding if feeding time exceeds 3 hours per day. And this assessment algorithm I thought was really nice. This kind of really just shows you whether or not this child needs feeding support. So whether they're getting adequate nutrition or inadequate nutrition, whether that nutrition intake is safe or unsafe. And it really kind of shows you how you can attempt first to optimize nutrition without putting in a G tube. Ensuring positioning is appropriate, consistency of the food is appropriate. But if that intake is still unsafe, tube feeding, of course, is recommended. If they have reflux disease, then if they don't, then a gastrostomy might be perfectly fine. If they do, then potentially they could have PPI or a change in diet. And then also potentially they suggest a gastrostomy with fundoplication. I know in the U.S., especially fundoplication, many centers are moving away from that. A jejunostomy also might be indicated in this case. And I want to talk a little bit about some of the issues that may interfere with adequate nutrition in this next section. So gastric emptying. Obviously these children tend to have lower muscle tone and function. So certainly the GI tract will be affected by this. And that's why many of them have issues with GI impairment. So gastroesophageal reflux is a frequent complication in these patients. And it can, of course, result in undernutrition or risk for aspiration pneumonia. And delayed gastric emptying is a factor in gastroesophageal reflux. The rate of gastric emptying is can be associated with the type of protein that's in the enteral formula. So gastric emptying tends to occur more slowly in patients that are fed a casein predominant formula than those fed a whey-based formula. So, you're going to see typically in an enteral formula casein and or whey, sometimes soy protein or other plant-based proteins. But whey protein remains liquid in the acidic environment of the stomach. If you have a casein-based protein, when it hits that acidic environment, it curdles, so it forms chunks, and then it tends to stay in the stomach longer. It doesn't empty as quickly. So whey protein can be helpful with motility disorders. As it remains liquid, it tends to empty faster from the stomach. And demonstrating this is a very simple kind of chart that I'm showing from the Fried study. This is a study that was done by Fried and Kashu, looking at children with spastic quadriplegia that had documented delayed gastric emptying and frequent vomiting on a casein-based enteral formula. And so what they did is gastric emptying scans after 60 minutes and 120 minutes with both the casein predominant formula and also a whey hydrolysate formula. And you can see the purple bar is the whey hydrolysate formula. The gastric emptying was much faster with the whey hydrolysate formula. So you can see that can help in terms of gastric emptying and potentially help with gastroesophageal reflux. What does the ESPGHAN work group say? They suggest modification of enteral nutrition, either a whey-based formula or thickening of enteral formulas. I know in the U.S., there are many centers that don't thicken enteral formulas. They would more readily switch to a different protein source, in addition to other therapeutic options for gastroesophageal reflux disease. I wanted to show this study that was done in 2016. This was done at Joe DiMaggio Children's Hospital in Florida, and it's titled Formula Switch Leads to Enteral Feeding Tolerance Improvements in Children with Developmental Delays. And this was a retrospective study. This was done to evaluate improvement in feeding tolerance parameters in children who were on an intact protein formula, were having symptoms of intolerance, and then were switched to a 100% whey peptide-based formula. So again, this was a retrospective review of these children, and the authors looked at enteral volume goals, calorie goals, changes in their medication that were used to improve feeding tolerance. So actually, I'm going to skip to this slide because this really shows the results of the study much more in a visual context. And this looks at tolerance parameter changes before and after the formula switch. So again, these were children who were on an intact protein formula, and they were having a number of different tolerance challenges. And you can see the number of children that were having those tolerance challenges and what those were in the blue bar. This was before the formula switch. Vomiting, gagging and retching, high residuals, constipation, diarrhea, and poor weight gain as a result of these things. And then after they were switched to a 100% whey protein formula, how many of those children were having the specific symptoms. So you can see the improvements after the switch, the red bar. So obviously those symptoms went way down after the formula switch. And also, of the 8 different medications that were administered to improve feeding tolerance, 6 were used in fewer subjects after the formula switch, and none of them were increased after the formula switch. So you can see on the right-hand side in that table, all of the different medications. Some of these, erythromycin improves gastric emptying. There's medications here for treatment of ulcers, antacids, laxatives, probiotics that are used to treat diarrhea, et cetera, anti-reflux meds, laxatives, et cetera. So really, another benefit of an enteral formula that's better tolerated and can help with gastric emptying is reduction in medication. And that, that's a benefit that, certainly we should all be looking at just in terms of complications from medications or side effects from medications, but also total cost of care. So that is a really nice result there. So the conclusion of this study was that switching to a 100% whey peptide-based formula improved feeding tolerance in these children. This is another study that I wanted to quickly outline. This was done by Cluj et al. This was done at the Children's Center in Bethany, Oklahoma. And this is a 120-bed facility, all chronically ill children. Many of them have developmental disabilities. And this looked at the effect of a low-calorie, nutrient-dense formula on the use of modular nutrition supplements. So as I mentioned earlier, you have very low energy needs in many of these children. Some of them need less than 800 calories per day. And then what this might entail is the use of a enteral formula. You're giving a very low volume because you don't want to exceed calorie needs. And then you're adding modulars like protein modulars, vitamins, minerals, those types of things to meet the protein needs and the micronutrient needs of these children. And this study looked at the impact of a low-calorie, high-protein formula. Specifically, this was a 0.6 calorie per ml formula with 20% of calories from protein, and how that affected the use of modular supplements in this population. And the results of the study were that prior to the initiation of this study formula, all the subjects were getting at least one modular. Most of them were receiving 2 or more. Again, those included supplemental protein, multivitamin, vitamin D, calcium, free water, of course. Most of these kids are certainly going to need free water. And then following the initiation of the study formula, no additional modular supplements were used to meet the patient needs, aside from just water flushes. So there certainly are formulas that can be used that are specifically tailored for a child with a lower calorie need and also higher or adequate protein needs. I'm looking at the time here, so I'm going to try to go through these last slides fairly quickly to leave time for questions. I think it's really important to talk about real food and blenderized diets. These types of diets have been shown in the literature to have a variety of different benefits. They can improve tolerance. They can reduce gagging, retching, reflux, diarrhea, and or constipation. Certainly, they can meet social and emotional needs by providing real food. This not only helps the caregiver feel better and the family feel better, but the child who's getting actual real blenderized foods, the same types of foods that their family is eating at home. These types of diets have been shown to improve bowel function, improve stool consistency, and help with constipation and diarrhea. So actual real blenderized foods have a variety of positive outcomes. And in the literature, if you're looking at some of the studies that show these results, patients that are shown to benefit from these types of diets specifically are G-tube-fed children with developmental delays, and children that are suffering from some of these poor tolerance outcomes like constipation, volume intolerance, reflux, when they're on standard formulas. Patients that are long-term tube feeders, of course, can benefit as well. And, as I mentioned, patients with intolerance. And then there was a feeding clinic report that specifically saw children with G-tube feeding that were developmentally delayed, and they reported some medical and emotional benefits by using blenderized tube feeding, normalization of the feeding process, greater volume tolerance. I've already mentioned some of these outcomes. Reflux and constipation were improved. And then also transitioning from tube feeding to oral feeding. Obviously, when they are feeding orally, these are the types of foods they're going to be eating. And so, many caregivers are choosing to make their own home blenderized tube feeding, which is great. There are some challenges of blenderized tube feeding at home. Preparation can be labor intensive. There can be some uncertainty about the nutritional value, especially if this is a child that's getting all of their food via G-tube feeding or J-tube feeding. Hospital and home prepared formulas can, again, have unpredictable levels of nutrients. And, there could be a risk of tube occlusion due to the consistency or the viscosity. Certainly these need to be made with a very high quality blender, an industrial grade blender, to make sure that there's not any big chunks and it can really be delivered through the tube. So many, there certainly are a number now of commercial blenderized tube feeding products that can be used for, caregivers who prefer blenderized tube feeding, but can't always blenderize at home due to time constraints or whatever the case may be. So there are a lot of options now for caregivers and patients who prefer blenderized tube feeding. And in the interest of time, I'm not going to go through all of these, but these are some of the formula recommendations from the ESPGHAN work group. So they're looking at, a couple that I will point out. 21D, they're looking at a low-calorie micronutrient replete formula for children who are non-ambulatory. 21E, they recommend a Whey-Based formula in cases of gastroesophageal reflux, gagging and retching. 21F, they say they recommend caution if pureed food is used for enteral tube feeding because of concerns regarding nutritional adequacy and safety. Again, this is a huge, huge trend, and many people are now blenderizing at home and certainly can follow, food safety rules and things of that nature to combat some of these issues. I'm going to kind of rush through these last slides. I just have a couple left. I mentioned earlier that these children are at increased risk of fracture, especially those that are non-ambulatory. There are some studies showing reduced bone mineral density and increased fracture rates in children with neuromuscular disorders. Some of the risk factors can include, of course, lack of weight bearing, lack of sun exposure, insufficient calcium and vitamin D intake. And then those children that are on anticonvulsants, those medications can interfere with the metabolism of vitamin D and calcium. So that kind of worsens the problem. So supplements are sometimes used for treatment. There are formulas with higher calcium and vitamin D included in those formulations. Bisphosphonates can also be helping these children. And the ESPGHAN work group recommends the assessment of micronutrient status, and they specifically call out vitamin D and calcium as well as iron and phosphorus as part of the nutritional assessment. And then my last section here really deals with constipation. So this is a huge issue. Again, it's a GI motility issue. When you're thinking about reduced muscle tone and reduced muscle function, the GI tract is really a large muscle. So you're going to have potentially some issues with motility, especially if you're at a more severe gross motor function classification system level. Constipation has been reported in up to 75% of children with neurological impairment. And that can lead to hemorrhoids, it can lead to fecal obstruction, anal fissures. None of those outcomes is pleasant. And this can be attributed to decreased muscle tone and physical activity, lack of fluid and fiber. And fiber and fluid intakes have been shown in at least one study to be inadequate in over half of children with neurological impairment. And then certain medications can exacerbate that issue. And dietary fiber, of course, as dietitians, you all know the difference between the benefits of soluble versus insoluble. Soluble, especially prebiotic fiber, the fermentation of that fiber really has a variety of different benefits, health benefits, that prebiotic effect, including proliferation of good bacteria. And we're all hearing more and more about the diversity of the microbiome. It really has a variety of different health benefits. And insoluble fiber really just helps to add bulk to the stool and manage stool consistency. Here I've just kind of included the definition of prebiotic fiber. It has to be fermentable. It has to resist upper GI digestion. And that fermentation process really needs to produce short-chain fatty acids, specifically the short-chain fatty acid butyrate. And here I have listed just a variety of different benefits of prebiotic fiber. Again, we've all been hearing about the benefit of the diversity of microbiome. And the ESPGHAN work group, they suggest increasing fluid and fiber intake as a strategy to treat constipation in neurologically impaired children. So as dietitians, I think we all kind of know that, but just kind of keeping in mind when you're looking at enteral formula and you're looking at, feeding schedule and water flushes, making sure that that child is getting adequate fiber and fluid intake. So we covered quite a bit of ground today. In summary, the evaluation of the nutritional needs of patients with neurological impairment is complex. There's a lot of different assessment tools, though, that are available. Certainly, nutritional status is going to be key in terms of outcomes It can affect health, healthcare costs, quality of life. Some issues can include malnutrition, reflux, oral motor dysfunction. All of these can really affect outcomes. And standard growth charts or the Brooks growth charts, also alternative anthropometric measurements, those are all recommended as part of the assessment of this particular population. Many of them will need enteral support. There are specific formulas that might be helpful for these patients. Lower energy density formulas, Whey-Based formulas for improving gastric emptying. In some cases, energy-dense formulas for those children that have volume intolerance. Certainly you want to include fiber for many of these children. And then protein adequacy is really key for supporting lean body mass in these children. And then some of the nutrition-related issues that we covered, delayed gastric emptying, motility issues, intolerance. I've showed some evidence here today that the protein source can influence all of these factors. Also, higher risk for osteoporosis, a formula with higher calcium and vitamin D, or supplementation of those micronutrients, or bisphosphonates can all help manage osteoporosis. And we mentioned the addition of prebiotic fiber to help combat constipation, as well as additional fluid. So that concludes my presentation. Apologies that I kind of had to rush through the end there, but it looks like we still have a couple of minutes for questions. So here's the question, and this is a question from Katrina, who asked, do you have any info on the effect of pea protein on gastric emptying? How does it compare to whey? That is a really good question. Actually, there are some formulas that are available on the market today that do contain pea protein. So that is, certainly a very timely question. I started digging into this and trying to do a literature search on this a couple of weeks ago, actually. And there isn't a lot of data looking at gastric emptying with pea protein, but I was able to find one article that really the description of the gastric emptying was that it was somewhere in between casein and whey. So where you have a milk protein fraction of casein, that's going to curdle and form these larger chunks that's going to empty from the stomach much more quickly. Then you have plant-based proteins like soy and pea protein that aren't going to curdle, of course, but aren't going to remain liquid either, the way whey protein does. The best way that I can describe it from what I've read is that it's kind of in between, halfway in between whey and casein. So in terms of a child that really has an issue with gastric emptying, certainly a pea protein or a plant-based protein can be tried. If you previously had been using a casein-based protein, there's probably going to be some improvement there. But still, there is evidence that whey protein is the only protein source that is going to remain 100% liquid, and probably for that reason would provide the fastest gastric emptying. So again, there's not a lot of data on this, on pea protein, but that's really what I was able to ascertain based on the reading that I've done thus far. I hope that answers your question. Okay, well, I'm not seeing any other questions, and we just have 1 minute left. So, certainly if there are questions, you can email me, and I think probably Elaine can provide my email address to everybody, and I would be happy to answer any questions after the fact. But now, since, like I said, we've got 1 minute left, I just have a couple items to wrap up the presentation today. So first of all, I want to thank you very much. I want to apologize for the audio issues, but once I switched to my cell phone, it looks like we were able to go smoothly through. I do appreciate your participation today. On behalf of the Nestle Nutrition Institute, I hope that you found this information useful to your practice, and please enjoy the rest of your day. Thank you.